Good morning and also good afternoon, everyone. Thanks again for joining FSMA Friday for May 29th, 2020, with our continued coverage of the COVID-19 impact to food and safety. My name is Aaron Bolshaw. I'm the VP of Marketing for Safety Chain and today's moderator for FSMA Fridays. For those that may be new, we do continue to see a lot of new folks join our crew here for FSMA Fridays. It's an ongoing monthly industry update for food and beverage facility operators, QA, safety, compliance professionals, and we partner, the Safety Chain partners with the Acheson Group to bring you these presentations and some other thought leadership. So we're happy that you can join us. To start, very quickly, just wanted to make sure everyone knew we can't hear you. You can only hear us, but we do want to hear from you, oddly enough as that sounds. So please send us your questions through the presentation as you have them, okay? And we'll get to them at the end of today's presentation, as many as possible, though we continue to see a lot of great questions. We'll stay flexible too with our time today, since our topic is so sensitive, right? We expect we probably will go a little longer than 30 minutes again in answering some of those questions. So with that, I just wanted to welcome our esteemed guests, Dr. David Acheson and Dr. Ben Miller of the Acheson Group. Gentlemen, welcome back, and thank you very much once again for joining us here.
Thanks, Aaron. It's good to be back.
Thank you, Aaron.
Yeah. Good. So, guys, here at Safety Chain, we've been staying pretty busy, and we have a handful of customers now using COVID-19 Quick Start solutions quite successfully, with a report coming in this week that a director of food safety from a very well-known national direct-to-home consumer food company, the company put out, as many people did, as many of your clients did, put a requirement that all their manufacturing facilities quickly and very seriously start following social distancing and some other, travel bans and things of that. Well, this director was able to satisfy all these needs almost instantly with Safety Chain. The visibility of his efforts went straight to the CEO. The CEO called this director and said that he did a great job. And the company has 100% visibility into all their plants, all of their new social distancing programs and audits. And the CEO was kind of impressed because the CEO said, well, I get this all on my smartphone. And so, again, I know you guys are staying super busy too. I mean, there's just a lot of, this has just been a huge disruption, right? And we're now starting to talk more about the rebound from COVID-19, and we're hearing that more states are opening up now. So this presentation does cover a lot of ground. With that, I'll hand it over to you, Ben. Why don't you take us through what we're going to be talking about today, and we'll jump in.
Sure. Thanks, Aaron. Yeah, as you mentioned, we're going to be covering a variety of topics today, talking about updates to testing and what you might need to look for when thinking about testing in the workplace, talking a little bit about the variation that we're seeing in terms of state and local responses, and then some of our current thinking on travel considerations, when you think about what's a safe way to travel, how do different modes of transportation vary from a risk standpoint, and then talk a little bit about some of the analysis that we've been doing around state reopenings and trying to classify the current state of states, if you will, in terms of risk. So with that, I know David's going to start, so I'll turn it over to him and I'll pick up in a bit.
Thank you, Ben, and pleasure to be with everybody again this morning or afternoon, depending where you are. As always, the one consistent message with this COVID-19 pandemic is stuff changes. It changes all the time, almost on a daily basis. And I think a late breaking update that I just want to share before we get into some of the content here is just in the last 24 hours, CDC has put out an updated guidance document around information for office buildings. Won't get into that, but it's a very comprehensive guidance document that talks about multiple factors, including raising some of the issues that come up regularly about airflow And what should we do with the HVAC systems? And there are some interesting recommendations in that, which we can get into in Q&A if anybody's interested in it. But they also reference, say, what I've just taken a quick look at, a good reference document published by the American Society of Heating, Refrigeration, and Air Conditioning Engineers, which talks about controlling the movement of infectious diseases, disease agents. It's sort of more centric towards perhaps the medical industry, but it's of relevance to all of us in office settings. So everything changes very quickly and constantly. Hence, if you're not signed up for our daily updates, then do feel free to do that. So with that, let's go on to the next slide. Message number one is we are maintaining our drumbeat around maintaining the basics. Is looking at, and this is a pyramid that we've shared before. We continue to enhance it. We're looking at progressive risk mitigation strategy as we move up the pyramid in terms of looking at who's essential, how do we manage that, and that sort of becomes more relevant perhaps in an office environment as offices start to open. Corporate entities are looking at, should we keep people out, should we bring people back, how do we do that, should we bring everybody back, should we bring some back? And that's just remembering to look at essential versus non-essential. Then building that up through the structural controls, the wellness checks that we've talked about, the communication, the training. Building that on top of that, you've got your preventive measures, the social distancing, and CDC makes a big deal about that in that document that I just mentioned, that new guidance document. The 6-foot social distancing remains a key part of the prevention. If you can't do that, then barriers, physical barriers, face coverings, all of those are important. On to clean environment, the touch point cleaning. We know the virus is surviving on surfaces for a couple of days. There isn't a lot of evidence that it's spreading a great deal from contact surfaces, but it is to some degree. And then obviously recognizing that this virus spreads in those aerosols and respiratory droplets from individuals who are carrying the virus, whether they are symptomatic or not. And so face coverings remains an important part of the mitigation. But this is just remembering enhanced risk mitigation as you move up through these multiple steps. And that's really the bottom line, is how that works. So as we translate that into employee wellness checks, social distancing, enhanced cleaning, and face masks. So let's go to the next slide. I want to just talk a bit about testing. Obviously, in the time we have together today, we can't talk about every aspect of COVID. So Ben and I have sort of picked up a few things which we're getting a lot of questions on. Testing is one that we get asked about every day. And that first point is still key. It was key when we met a month ago. It's very much key. What am I going to do with the data? Should I get a test? Well, yes, maybe you should, but what do you do with the result? Number one, make sure that if you're thinking about having the workforce tested or going to a test, then make sure that it's got at least the current approval available from FDA, their emergency use authorization process. We want to make sure that that's in there, that any swabs that are taken are done by medical professionals, people who know what they're doing, and that any lab who's doing the testing has all the right programs in place for doing clinical result testing. These are important things. These can change people's lives and views of how they are, whether they are based on a result. So it's important that we do them right, we use the proper tests, and we do them in a lab that really knows what it's doing and does it every day, i.e. a clinical lab, and that's what clinical labs do. When it comes to the tests, we've got basically the looking for the virus test, the molecular or even some antigen tests. And we've got the looking for the antibody. In other words, that there's an indicant of a prior exposure. Let's go to the next slide. Should we be testing our workforce? It's a question that comes up. Should we test everybody every day? How do we do it? And I think that certainly increasing diagnostic testing is a way to identify asymptomatic carriers of the virus. And as companies and individuals and groups have done testing, what they found is that there is definitely a significant number of individuals who feel fine, never felt sick in the recent days, and yet are carrying the virus. Some of them go on to get symptoms and some of them don't. So the testing will pick up those who are asymptomatic. Employee wellness checks, do you have a fever, do you have a cough, how are you feeling, do you have aches, are obviously only going to pick up symptomatic cases. The wellness checks are important to continue to be done, and particularly adding the question, have you had contact with anybody or been in close contact with somebody who's been diagnosed, is an important part of that daily questioning. But it is going to only pick up symptomatic cases. If you get into testing, there are a whole series of practical implications that we've listed out here. Is this testing going to be required or is it going to be optional? What's the turnaround time for the test? Keeping in mind that when you test for the virus, it's a point in time test. You have the test taken at 9 o'clock on a Monday morning, you get the result at noon on Tuesday. It tells you what your status was at 9 a.m. the day before. You may have picked up the virus in that time frame in between. It is a point in time test. So it has value potentially in finding asymptomatic carriers, but it can be difficult to manage ongoing risk. Will you exclude people who've had a test until you get the result? That's the safest thing to do, but if you test a lot of people, you don't have a workforce. How often are you going to get your workforce tested? Every day, every week, every month? What's the right balance? There isn't a good, clear answer to do that. Are you going to test everyone at once? Are you going to test 25% at a time? If you test a small group, what percent positive rate would trigger you to do something different in the plant? I.e., we're back to what do you do with the result? When you do the test, how reliable is it? Is it most of them are running maybe 95, 96% accurate, which means we've still got a 5 times out of 100 chance that you'll get a false result. Cost is a significant factor with these tests. They're still expensive. So think about that as you're debating about whether or not to do a test. And obviously, in terms of the percentage of the workforce that's tested positive, looking at that, again, it's a useful statistic. But the point here is there's a lot of things to think about before you launch into a testing strategy. Let's go to the next slide. As we think about this, I think one of the ways to approach this is, as I said, is to look at all of the questions before you launch into a testing strategy. Get into the thought process of, if I start to do testing, how am I going to do it? And there's different ways to approach it. You can test people before they come back. You can test people who are symptomatic. You can test contacts that you've excluded. You can test everybody if you decide to do that. But it's really important to think through the different scenarios and plan for what you're going to do with the results. Some of the fast turnaround tests that look like they'd got great promise have turned out to be a little bit more of a challenge with results that are not nearly as accurate as we had hoped. So again, looking at that very specifically is going to be important. And geographically, it's different. There are certain parts of the country where getting a test is easy. There's other parts where it's still difficult, and you simply cannot get a test if you want it, despite all the statements that tests are readily available. In some parts of the US, they're not, and they're only being done in people who are sick. Let's go to the next slide. with that, that's sort of a brief overview of testing. I'm going to hand over to Ben to round out our presentation before we get into Q&A, because he's going to launch into some of the differences in state and local responses. So Ben, I'm going to hand it over to you.
Sounds good, David. Thanks. So this slide speaks to just some of the variability that I think we've seen in terms of response to managing COVID illness or COVID-related illnesses in the workplace. So certain states and certain counties or cities, even within those states, I think we've seen a variability in response. So we've seen facilities being shut down by certain local units of government because they have a high incidence of illness at a particular period of time. We've seen other facilities that have been inspected by the states and actually have the CDC along for that inspection, and OSHA as well, to look at what preventive measures they've instituted. These tend to be in locations where the prevalence of illness is higher, but then we've seen other states where there just doesn't seem to be a capacity or even necessarily interest in hearing from companies if they have experienced positive cases in the workforce, and that's somewhat an effect of just the varying public health capacity in different regions of the country. So it's an important data point, I think, depending on where you have facilities, knowing sort of what the stance of the state or local jurisdiction might be relative to wanting to know about illnesses in your workforce, especially if you're a larger employer or have a significant number of employees in a particular facility. Certainly some states have seen significant increases in their illness counts because of a high incidence of illness within a particular population that may work in facilities where social or physical distancing is more challenging. So the CDC has also developed a bit of an inspection checklist that they've gone through and used in some of these inspections and provided to local and state public health authorities. We found that in reviewing that checklist that our toolkit that we've developed is really quite well aligned with everything that the CDC checklist and guidance has been looking for. So I feel confident that those that we've been working with and advising have received good advice, and if they're implementing our recommendations, that they're well prepared for these types of situations. I think the other question that we've been receiving quite frequently is around travel. When is it safe to resume travel? When is it safe to get back on an airplane? And like everything these days, the answer to that is it depends. We've developed some travel recommendations as part of our toolkit, and this tracks pretty well with what we've put in place. So first and foremost, obviously, only non-symptomatic people should be traveling right now. If you have symptoms or if an employee has symptoms, they should not be, traveling or out in public. Certainly, if they're coronavirus-related symptoms. The next several questions are, is that travel essential, and is the destination high risk? So, from an essential standpoint, does somebody need to actually physically be at a location? Do they need to install a piece of equipment or repair it? If not, are there alternative approaches that can be considered, either virtual visits using real-time video screening or video recording, web meetings, virtual document review, things like that. If that travel is essential, is the destination that they're heading currently high risk? There are certain requirements for states, let's say, at this point, that if you're coming from out of state, that there's an expectation that you quarantine. Now, enforcement of that is obviously sporadic, and that's a question, but it's good to understand what the government requirements are, both from the location where you're departing. So if you leave somewhere and come back, is there an expectation that you quarantine, or for the location that you're heading? Where that will be enforced is not in domestic travel so much as it would be in terms of international travel. Somebody traveling to Australia right now will be met by the authorities and required to quarantine for 14 days before they can travel freely around the country. So that's an important thing to understand. The other piece is, if you do decide that travel is essential and that it's in an area where you can go without quarantining at arrival, it's important to understand what the facility that you're visiting, what kind of preventive programs do they have in place? So do they have the same kind of programs that you have in terms of employee wellness checks and mask usage and social and physical distancing? And have there been any recent illnesses within that facility, say within the last 14 days? Those are data points that are helpful to determine if that's a safe facility to visit, if it's not one of your own. Next slide. And this slide just shows the continuum of sort of risk when we think about the mode of travel. So obviously, driving alone, that was one of the recommendations that came out of CDC's office, or kind of return to office guidance, was the safest way right now to get to work is to drive there by yourself, which is, it stands to reason, but also can be a challenge depending on which part of the country you're in, what the infrastructure is. As we move up that risk continuum, you've got driving with people that you're already close contacts with, driving with somebody that might not be a regular close contact. So if it's not a roommate or a family member, it would be somebody like a colleague, but that you're not a regular close contact of. As we continue looking at ride sharing or taxis, obviously that's a higher risk, or medium risk in the continuum, but higher risk than driving with a colleague. Public transportation, airports, and then finally airplanes at the far end of the spectrum. Next slide. Next slide here. There we go. A little bit about airline travel. From our standpoint, I think it's important to understand and verify what the airline's current policies are. Some airlines are stating that they won't sell the center seat, but that doesn't mean that they won't seat someone in the center seat, or that they'll only board to a certain capacity to then later consolidate a flight and have a flight that's above capacity, or what their policy might state. So it's important to know what those are, and if the airline's actually doing what they say they're going to do. There was a report in 2013 from the National Academy of Sciences, and you can go and find that online fairly easily. They looked at the risk of transmission of in-flight of infectious diseases, not SARS-CoV-2 necessarily, but other infectious illnesses, influenza, tuberculosis, SARS, back when they conducted the report. And what they found was that the risk of transmission in flight may be fairly low, just given the air exchange within the cabin. You're bringing in 50% fresh air on a regular basis from the outside, and that air generally flows within kind of 2 rows in front of wherever you're seated and 2 rows behind. So it's not that the air is mixing fully throughout the cabin, but there are periods of higher risk. So when the plane's landed at the gate, depending on the construction of the plane and the gate, you may not get that fresh air turnover if the plane's operating under auxiliary power. And I think we've all had that experience on airplanes. We walk in and find that the air is fairly stale. That can constitute a period of higher risk of transmission. And so, certainly universal mask usage is something that's airlines have put in place from a policy standpoint, and that helps reduce the risk of short-range aerosolized transmission. Compliance, everybody needs to be wearing one for that to be effective, and so that can also be an issue. If you have passengers that refuse to comply with that policy. There have been some documented outbreaks, particularly of SARS, so back in the early 2000s. And one in particular, there's a paper out there about transmission on a 3-hour flight in China that resulted in 18 cases of illness. So there's certainly evidence that viruses can be spread in flight. And because of that, and because of sort of the uncontrolled nature of air travel, it's our current recommendation to provide voluntary use of like an N95 respirator if those are available. That provides a little more respiratory protection to the wearer than just a standard loose-fitting face covering or mask. All right, now talking a little bit about testing in states and sort of risk profiles of states. So how do you determine if a state is high risk? Look, we've seen states reopening. What does that mean from a virus control or potential resurgence standpoint? We have seen a really significant increase in the amount of testing in states, and I think David mentioned that, but it still is fairly fairly uneven. And some states are combining their diagnostic and antibody testing results and the results that they've been reporting on a daily basis. And that has that muddies the water in terms of how to interpret the successfulness of their testing and the number of positives that a particular state has. So Virginia, for example, stopped that practice once it was identified in the press. Other states, it's still a variable, and CDC has been doing the same thing, as you may have seen in the press. Next slide. So this graphic shows just that difference in testing rates from state to state. So the orange line here is the tests per 100,000. So at the far left, we can see Missouri, which is testing at this time period, May 18th to the 24th, at about 87 tests per 100,000 people. And then you see that of all the tests they've taken over that time period, that 12% came back positive. So at the far end of the spectrum, you have states like Missouri and others that have a fairly low testing rate, but a high percent positive rate. That suggests that the testing capacity in those states is not adequate, and that the outbreak may be uncontrolled in those states. And then at the other end of the spectrum, you have a city like Washington, D.C., very high testing rates, but also very high positive rate. That suggests that the outbreak is well characterized, but still significant in a location like Washington, D.C. And then you have other states like Rhode Island on this map that are doing a lot of testing and are not having as quite a high percent positive rate. So that shows that surveillance testing is probably adequate in a state like that. Next slide. And this is, we've talked about reopening, and so what does that mean? This is a map that comes from the U.S. Chamber of Commerce and was updated about a week ago. And so you can go look and download the more current version of this if you'd like. But wanted to compare it to some modeling that's come out of the Imperial College. They use a fairly robust epidemiologic model. And so, when we look at states that have started to reopen, and then we look at the effective transmission rate, that's what the map that shows the green and purple shows. The more purple the color, the more likely that the effective transmission rate is over 1, which means that the outbreak is potentially growing in those states. So where we've seen relaxation of policy, in some areas we've seen the outbreak maybe never slowed down, or that it started to then increase. And I think we've seen some stories in the media just over the past few days that speak to this as well. Starting to see a significant uptick in cases in states like Wisconsin and North Carolina. So this will be something that we need to continue to monitor to understand which locations have the outbreak under control and which ones don't, both from a facility management standpoint, but also from a travel standpoint. Next slide. So to answer that question, we tried to develop a risk matrix that looks at where states are falling out relative to social distancing. So how much are people moving around relative to how much they were moving around before the pandemic, and then a couple key outbreak measures that include the effective rate of transmission and then that test positive rate that we've looked at before on that previous graph. So that creates an outbreak index as well as the social distancing index that we get from the University of Maryland Institute for Transportation. And they look at anonymized cell phone data from Google and Apple, like over 100 million data points a day to come up with their social distance measure. So next slide, when we graph that out, we get the placement of states within sort of a risk quadrant model. And this works in looking at the darkest red color, that's sort of the highest risk quadrant where there's less social distancing and the dynamics of the outbreak are less under control, which means that the likelihood that the outbreak is increasing in those states is greater. Then we move up to more of the amber colored quadrant in the upper right-hand corner, and that's high risk. That might be where the outbreak is continuing to increase, but people are staying home more, and so transmission hopefully will reduce and move over to that green quadrant, which is lower risk. But that's states where people are still not moving around as much as they did pre-pandemic, and the outbreak is decreasing. You can see that most of the states are falling out in this medium risk quadrant, which is people moving around more, but the outbreak has decreased during the stay-at-home and shelter-in-place orders that have been in place. There's a red box here that measures some of the states where we've seen an increase week over week. We run these data on a weekly basis and then look at the states and how they move around. The states highlighted in that kind of red box between the yellow and the dark red there are states like Missouri, Texas, Tennessee that have seen an increase in illness over the last week. And so those show up and are moving from that medium risk to high risk setting. And so we look at that cluster of states, especially in the medium risk, that's all kind of clumped together. Those are the ones that, you know, we want to keep a close eye on, because those are the ones that, as social distancing decreases, the chance that the outbreak starts to increase is there. Next slide. And this just shows that in greater detail. So really pulled out and tried to define this zone of concern, looking at states that show up within that blue box as ones that you want to closely monitor. So if you have a facility that's in one of those states or are thinking about traveling to one of those states, those are the ones to think about and recognize that the dynamics of the outbreak could change fairly quickly in those states and in those locations. Next slide. So looking through the summer, you know, this speaks, I think, to what we've just been talking about. How will reopening create ongoing hotspots nationally? And that's something that's of great interest, obviously, to all of us, and something that we continue to look at closely and try to communicate to our clients. You know, will testing technologies improve to allow on-site testing? I think so. You know, and FDA has talked about prioritizing rapid on-site testing for the food industry next, after the medical industry receives that technology. Clinical settings have been prioritized for some of these rapid PCR tests, but once that demand has been met, FDA said that that food and the food industry segment should be next in line to have access to that technology. And then how will consumer behaviors change as people start to plan for a second wave, potentially in late fall or early winter, that coincides with flu season? We've heard a lot about that, and that's probably our next highest risk period as we look towards the end of the year. Next slide. All right, thank you, Aaron. That takes us to the end.
Yep, thanks, Ben. And I'd like to point out there is a bit of a difference between the second wave and maybe a second peak there that we're talking about. And maybe you guys can just cover that really quickly, stemming from the last point you made, Ben, which is there's a somewhat of an expectation that in the fall this will flare up once again. However, that's separate wave than another second peak, should we see social distancing and some of the other measures not be as effective over the summer. Is that accurate to say there's a peak? There could be a second peak, but also the wave in the fall. Is that about right?
Yeah, I think you stated that well, and actually WHO was commenting on that earlier this week, you know, from a global standpoint. So the concept of a peak is a sharp rise in cases over a short period of time because of immediate changes in people's behavior, versus this concept of a larger wave that happens as we, you know, as it gets colder outside and we move back inside, and if, you know, kids go back to school in some capacity, you know, you just put more people more close together inside for a greater period of time. And we certainly saw that 100 years ago with the Spanish flu, and you know, we're concerned about seeing a similar thing happen this year with COVID.
Yeah, absolutely. Well, we got a ton of questions, as we always do. So again, we did go over our normally allotted half hour, but I think it's important that we tackle a couple of these. The first one came in from Mike, and it was a perfect question. Is it acceptable to replace face masks with face shields for control of droplets?
David, do you want to?
All right, I'll go for it.
Sure.
You know, One word answer, no. You know, and let's just explore what I'm talking about. Is the purpose of wearing a face covering that is the most effective is to catch the respiratory droplets, the little bits of moisture that come out of your mouth and your nose as you, through daily living, coughing, talking, because it's those respiratory droplets, however big or small they are, that are carrying the virus, and that's what spreads to other people or to contact surfaces. So if you're wearing a face covering or a mask, it's the most effective tool to catch the droplets. If you're wearing a face shield, because of its nature, it isn't a droplet capture. It doesn't have absorptive capacity, and it's wide open on the sides and on the bottom. So a face shield, when you see medical professionals wearing face shields, they're wearing masks as well for the most part. And the value of a face shield would be to protect you from getting the virus in your eyes, but it won't protect somebody who's asymptomatically positive from spreading the virus nearly as effectively as a face covering. And I am being specific there with my language, because the issue around masks continues to be contentious and difficult. And I think CDC has made it very clear that they believe a face covering, a cloth mask, homemade, whatever, goes quite some way to catching those respiratory droplets in symptomatic people. So, you know, I feel, you know, the two are not the same. And the notion of a face shield and a face mask is doing the same job, I don't believe is true. And it's not, a face shield is not as effective in doing what a face mask or face covering is designed to do. Ben, what would you add?
Nothing. I think that was perfect.
Yeah, I think that does speak well to, you know, the difference between those droplets and then that aerosolization. You may catch some of the droplets with a face shield. You're not going to catch it all. And so it just shouldn't be used that way.
Yeah, so they're not interchangeable. I think that's the key message, and so I think that's the point, and that's a little bit why they're not interchangeable. They're doing a different thing.
Yep. Good. Okay, well, next question here, excuse me, from Quincy. What is your opinion? And I like how Quincy's worded this, because this can be, you know, characterized as one or the other, but what is your opinion on allowing third-party food safety auditors and or food safety inspectors to come onto premises?
Ben, why don't you go for that one?
Sure. Yeah, you know, I think if you take that guidance around travel and sort of use it in the reverse manner, you know, thinking about visitors, you know, where are they coming from? You know, how did they arrive? How did they get to your facility? Sort of what risk profile did they experience as they traveled? And then, you know, how do you move them through your normal screening process? So do you have a screening process in place for visitors the same as you would for employees? You know, and is there an expectation that they wear a mask on site when walking through the facility? I think there's a practical reality too, in terms of, you know, when an auditor might be walking through a facility to make observations, and then what work do they need to do on site? You know, so do they physically need to be there for record review or document review, or are there ways to set that up so that that can be done offsite, either ahead of time or afterwards? You know, if they need to be on site and actually handle the physical documents, how do you set them up in a space that they can work in independently, you know, so that you're not coming into regular or constant contact with them? And then if you need to have a conversation on site, it may be best to do that remotely on site using, you know, Skype or, you know, Microsoft Teams or GoToMeeting, whatever your package you happen to have, so that you're not sitting in a conference space with them for an extended period of time. You know, what we know about transmission is it's, you know, it's distance, duration, and intensity, right? So you want to avoid the situations where you're sitting in, you know, a small space with somebody for an extended period of time if that person's not a regular close contact.
Yeah, that makes sense. And you know, Quincy, that's a good question. We hear from our clients a lot as well. If you're interested, we can follow up with you with some of the solutions where our customers are seeing success with. So Next question from Dan. Is there an optimal time period to conduct a COVID-19 test for employees who are exposed to a COVID ill employee to help ensure they are actually okay to come back to work? And I will say he has understanding, of course, they can return if they wear face covering, are screened, and are not exhibiting symptoms.
Yeah, I'll give a shot at this one. It's a complex question, a simple question, but a complex answer, Aaron. And I think, the optimal timing is when you are exposed to the virus. There's a period of time where the virus is taking hold. It's gaining access to your cellular systems. It's beginning to multiply, and it's just not present in large enough numbers for detection. Then it gets up to the point where it's detectable and you're asymptomatic, and then it gets to the point where it's detectable and you're symptomatic, and then it go down the other side of it. It gets to the point where it's still detectable and you are no longer symptomatic. So, at what point in that spectrum do you test? And there is no definitive sort of strategy to know whether someone's going to go positive on day 2 after exposure, or day 6, or day 8. The average is about of symptoms is day 5. So typically day 3 and 4, you'd be positive if you're average. I think part of the challenges are you could be viral positive and remain asymptomatic throughout. We have seen situations repeatedly now where individuals have they've tested, they've had symptoms, they've completely recovered, they've been retested, and they've tested positive with no symptoms. Others who have followed the CDC original protocols of 2 negative tests, the symptoms have completely resolved 10 days after the onset of symptoms, no fever. They've had a test that's negative one day, it's positive the next, then it's negative the next, it's positive the next. And the longest series of that we've seen is 6 days, 6 consecutive days where the result has flipped, positive, negative, positive, negative, positive, negative. So it's a fantastic question, but a really complex answer. And there's no definitive sort of, do it then and you'll be fine because you can rely on the result. Every case is just different, and we're learning. So, I think our approach to this is when you have these is, we'll share our experiences, we'll give you our best thinking on what to do with it. But I think both Ben and I would support strongly that if you're testing and you find virus, irrespective of symptoms, then the strategy of keeping somebody out who's viral positive, because we don't know whether they can still spread it, but we have to assume that they can.
Yeah, wow, that's amazing. Testing, you keep hearing it. Here's a good question, and I think we've got time just for 2 more. And I know there's a lot more questions, and so everyone just that's on the line, just a quick reminder that we'll follow up with you. We've got your name, your email. We're not sharing that with anyone, but we do also have that question, and so we do want to make sure that we're getting back to as many people as possible. Diego is asking, could you talk about HVAC cleaning? Is additional disinfection needed? Is routine cleaning enough? What are the thoughts about HVAC?
Ben, do you want to give that one a shot?
Sure. I think, and you can speak, I know, David, to some of this as well. There's, evidence that HVAC cleaning in and of itself, we don't think the virus is spread through the HVAC system necessarily at this point. So cleaning of those systems isn't necessarily going to reduce the risk of transmission, although I do know that there's some emerging thoughts in terms of treatment within the system itself that may be helpful, and I know there's some ongoing research within that space. But right now, the primary concern is still that transmission from somebody that may be actively ill or asymptomatic, to those immediately around them, and how do those small droplets move through the air into the HVAC system, but how do they pass by people that could then potentially be infected? So I think it's thinking about air movement and air flow sort of prior to filtration that has the greatest impact on risk mitigation at this point? David, some additional thoughts?
Not much, Ben. No, I think that this is an open debate, and I think that Ben summarized it well, and this is definitely an active area. And for those that are interested, we're going to dive into more of that on our tag daily updates next week. So stay tuned.
Yeah, good. All right, last one. This is a good one because it's kind of an example. So hear me out, and then we'll wrap it up, guys. So here's an example. A processor has 175 employees. Okay, they have 2 ready-to-eat rooms. They were closed for 2 weeks due to many employees with positives. Okay, they perform deep cleaning and sanitization and those things. They're running again. Okay, what is your opinion of this kind of, and quote unquote, known positive facility and their ongoing cleaning, fogging, et cetera, of the plant? There are a couple of outside labs also offering surface tests for COVID in food production areas, likely using indicator organisms. Give us a sense of what's going on here, what you'd be concerned about, and any guidance.
That's a great question, and let me start, and Ben can add. First of all, I think that one has to treat every facility today the same, whether you've been closed and are reopened, or whether you haven't closed, or whether you've had 1 case or 50. All of the strategies, going back to the fundamental pyramids, need to be followed. The wellness checks, the follow-up, keeping people out, all of those programs, the cleaning, the social distancing, all of those factors need to be maintained for the foreseeable future as we continue. We talked a few minutes ago, Aaron, you and Ben, about peaks and waves, and we're not out of this yet, and we need to continue to keep our eye on the ball and follow through. We're doing well. Critical infrastructure is doing well, not universally, but overall we're doing pretty good. So don't take your eye off the ball, and I wouldn't change anything in a facility like that. Do all the same things. When it comes to testing for the virus in the environment, that's a contentious one. There's definitely groups, a number of them out there, who are looking to sell tests to test for residual virus. Our view of that is that it has minimal extra benefit, frankly, to what you're doing. You should be cleaning the touch points. You should be using a disinfectant that's working, and you should be doing it often enough to help reduce contact surface risk spread. And as we've seen from CDC, they're basically saying, yeah, it's important to pay attention to that, but they don't consider that to be a major cause of transmission of the virus. The challenge too with testing is, if you find a positive result that's based on RT-PCR, it tells you that there's residual genetic material, RNA. Doesn't tell you the virus is alive or dead. And we've definitely had a number of situations with clients we've worked with who've called us up and said, we've got this great program, we did all this testing, and then we found all this virus positive on our contact surfaces. What should we do? And you go back and you explore it, and it's like it's dead virus. So that's my view on that. Ben?
Yeah, I think that's right. And I think the other thing is that it's talking about, or the question sort of pointing towards, what's the risk of ongoing transmission within the facility. I think, as we've seen, we also need to think about the workforce as a population that exists obviously beyond the facility as well. So from a facility standpoint, you can do a marvelous job in terms of putting all the preventive measures in place that we've talked about. But a piece of it too is that employee education component, and making sure that, especially as states move to reopen, and it's becoming summer and it's natural, we all want to get outside and we want to get together with people, that people understand, the risks of, what can happen in those settings as well. And, what somebody does outside of work obviously has an impact in terms of the workforce when people come back to work together. So, I think that speaks to education, empowerment, trying to create a culture of responsibility and, let people know that it's important, what they do outside of work as much as what happens inside of work in terms of protecting their family and their colleagues. So I know that's going to be an ongoing conversation, and we've certainly had conversations with companies and their workforce and answered questions, created an open space for dialogue, and I think that's going to be critical as we move through the summer.
Yeah. Good. Well, doctors, thank you very much again for providing great insights. Appreciate every minute we get with you, and I know I'm speaking for everyone that was on the phone. Several hundred people that were on the phone, and thanking you for joining us again. And again, we'll be back June 26th for FSMA Friday. Go invite some friends. LinkedIn. Join us out there on the social media. Go sign up for the tag newsletter. Let us know if you're having problems. We're here to help. So, gentlemen, thanks again.
Thank you all.
Thanks.